Use of atherectomy to debulk a lesion, novel use of Fox Hollow atherectomy catheter, Dr. Ramesh Adiraju.
I think I have another topic later on. There's two topics, one about bifurcation and one is the atherectomy. My presentation for the atherectomy case was not working, so I'll use the other one where I use Silver Hawk. So just combine the two topics, it'll be for want of time. The two topics I was supposed to speak on today was use of atherectomy for revascularization and also bifurcation stenosis management tips and tricks. So
you are going to talk on bifurcation stenosis.
Right. This presentation is working, which actually involves Silver Hawk. So
okay.
He could explain both ways.
Sure.
Bifurcation stenosis, as everybody knows, is a Achilles heel of interventional cardiology. Dr. Colombo has done a lot of work, multiple different approaches of stenting, V-stenting, T-stenting, crush stent, mini crush, cross-colute, all of which have the same problems in long term, which is stent thrombosis, higher restenosis. So in bifurcation stenosis, particularly major bifurcation, I'll just go over what I mean by major bifurcation stenosis. I've utilized directional atherectomy to debulk the lesion, so if you need to, you can minimize stenting by just putting one stent on the main vessel or sometimes the branch vessel if it is. It's a big vessel. This is the topic that I was invited by Dr. Colombo to present at the GYM meetings this year. So I'm going to use that presentation to explain atherectomy in general. So here's a definition of what I mean by major bifurcation. If there's a bulky lesion and the side branch is as big or bigger than the main vessel, angulated stenosis, type 2 diabetics who have diffuse disease and restenosis is high in these patients. These are the cases that I tend to try and use Silver Hawk, which is the directional atherectomy catheter. I'm very comfortable using. I've done a lot of work on peripheral vascular disease using atherectomy. So I use Silver Hawk atherectomy for coronary indication, which is the topic to discuss today. A few things to, a lot of myths and beliefs in using atherectomy, especially in bifurcation stenosis. People are nervous about using atherectomy, whether it's directional or rotational. If you have a second wire in place, I've had a lot of experience with this. It's pretty safe, it can be done with few tricks to do them. You may have to pre-dilate an angulated lesion or a very tight lesion before you use the atherectomy, so you minimize cutting the wire or delivery of the atherectomy device. The key about atherectomy is to commit yourself to use the device to the optimal extent. Optimal atherectomy is key to a long-term success if you have to use atherectomy for coronary revascularization. If necessary, you might have to keep reassessing the lesion and go multiple cuts, piecemeal approach till you get residual stenosis to less than 20%. If you remember, the atherectomy trials in the history of angioplasty included, the old Boats trial were all shown to have a high restenosis rate, and that's why people gave up atherectomy. If you look at sub-analysis of these trials, they've left 38 to 42% residual stenosis and then ended up finishing the case using balloons or stents, which is just glorified angioplasty. That's not atherectomy. So if you need to do atherectomy and have good long-term results, you have to commit to the device. That's an important point. I tend to minimize stenting when I commit to atherectomy, since that's a cost-effective measure and is also not necessary if you really get a good result with atherectomy. Major atherectomy catheters have been around. Most of the flexotome or directional atherectomy catheters are bulkier. In fact, I've had a lot of experience, as I said, with Silverhawk. The smaller version of the Silverhawk device works very well in coronaries, and we've had a lot of experience with it. Without further delay, I'll just discuss a couple cases to make a point. Yeah, the light's down. I can't see anything myself. This is a case of a 54-year-old female diabetic patient post-bypass surgery who presented with a non-transmural myocardial infarction. As you can see, a right coronary artery graft was previously.
Can the audience see the pictures? Can we have the lights down, please? Okay.
Is that better? Yeah, now I can see it better. So she presented with a non-transmural myocardial infarction. This is a vein graft to the right coronary artery. Why is this not playing? This is a lima to the LAD. This is what I mean by diabetic vessels. Even though the lima is open, the distal LAD is pretty diffusely diseased. This is typical diabetic vasculitis, which is why stents don't work that well in these cases. And here's the problem. This is a bifurcation circ's disease, and graft to the circ was down, and she presented with a non-transmural myocardial infarction. So that's the culprit lesion. As you can see, this is what I mean by major bifurcation. The side branch is as bigger than the distal circ, and it supports the right coronary artery, which has a vein graft that's diseased and previously stented. So the long-term patency of that vein graft in the future is not that high. So we have to keep in mind that we need to preserve these two branches at any cost. So we decided to go with atherectomy and then provisional stenting. We double wired the lesion. After pre-dilating, used Silverhawk directional atherectomy catheter. As you can see, I went after the side branch before because that's the straighter of the two lesions, of the two vessels, and also it's bigger of the two. That's after the first pass. And then we did more atherectomy, which I again was mentioning about. Optimal atherectomy is the key for successful long-term restenosis. Did a kissing balloon. I can't see well if this is. Here's a follow-up on her 2 years later. The case was done in 2010. She then followed up. As you can see, the right coronary graft was gone, and now she depends on this. And maintaining patency of both the branches helped her survive the loss of the right coronary graft. Here's another case. Of LAD diagonal bifurcation. Again, the diagonal branch is as bigger than the distal LAD. Here we did not feel the need, sometimes of double wiring it initially, since it's a proximal lesion and also straighter shot. This was after first pass Silverhawk. Then we double wired, kissing ballooned in. had an excellent angiographic result. As you can see, the disease here starts from proximal to the bifurcation. So this is the case where I decided not to stent it, because again, you don't want to jail the branch and risk stent thrombosis, which is higher when the stent is in bifurcation. In acute presentations, he actually presented as a STEMI. This is same patient 4 years later, or 2 years later, sorry, 2005 to, in the vessel, as you can see, both the branches remain patent. At the place I have is a Renousier Research Institute in Pennsylvania, Philadelphia, Pennsylvania, where we've developed novel approaches to manage complex disease. Silverhawk atherectomy is one of the things, especially bifurcation, in-stent restenosis, and osteal disease. We use directional atherectomy heavily. Based on our experience with Silverhawk, I don't advise Silverhawk to be used in coronaries as a ad hoc device that you can pull off the shelf. You need a lot of silver, you get to have a feel and experience with the device, which I would recommend you do it with peripheral vascular interventions. Because of our experience with peripheral vascular disease with Silverhawk, we attempted Silverhawk. As you can see, we've done renals with Silverhawk, osteal renal disease, in-stent restenosis, subclavians, and then ventured into coronaries. Thank you.
Thanks for the presentation. we have experience with Silverhawk in the peripheral vessels, but in coronaries, my experience we have is zero. What's the level of evidence and any RCTs of using atherectomy in coronary arteries? I'm totally unaware of this.
Are there any RCTs showing the results of, are there any randomized control trials for this device?
No, they're not. Actually, coronary Silverhawk is a totally out-of-the-box indication use. If I was at GYM meetings and also TCT this year, from talking around with Dr. Colombo and others who've been extensively using atherectomy and other devices, I don't think anybody else has attempted Silverhawk. So my experience is the only experience.
What's the size of the device which you use for coronary? Size of the device?
It seems to
I'm
be
sorry for my voice.
Right. Silverhawks, from LS to DS, there's a wide range of sizes that you use for peripheral vascular disease. But for coronary indication, SS, ES, and DS are the only ones that can be used, because anything bigger than that doesn't fit in 8 French system or lower.
How do you determine the size? Like, is it based on the size of the coronary artery? You have any sizing? How do you size the device?
How do you determine the size?
For Silverhawk, for coronary artery indication, the only ones you can use are SS and ES device. You don't go by size of the vessel. Differential cutting technique is what you use, and do piecemeal approach with the same device. Silverhawk, the advantage of Silverhawk as opposed to the other atherectomy device that we used to have is that it's not a over-the-wire system. It's a monorail system, and the Silverhawk, the newer devices have a natural bend that was built into the system to get more tissue. So the technique of delivering it, you can actually get more tissue with the DS-ES devices. You can cut 3540 vessels very successfully.
Okay, one last question.
Thanks.
Have you used it for left main bifurcations?
I haven't. I've actually used it for osteal left main, not done it for bifurcation.
Okay.